السلام عليكم وكل سنة وانتم طيبين. يا رب يبقى اليوم ثري ويوم علمي، يعني نستمع فيه ونشوف أحسن وأحدث الأبحاث في مجال طب المسنين. ما أقدرش أمسك المايك من غير ما أشكر أساتذة طب المسنين على دعوتهم ليا. الحقيقة بيبقى يوم سعيد جدا إن أنا أشوفهم وأشوف أبنائي من الطلبة اللي ساعدت إن أنا والدكتورة هدى كنا مسؤولين عن تدريس طب المسنين. فالحقيقه بحس بسعاده لما بشوفهم كبروا بسم الله ما شاء الله اساتذه ووكلاء كليه. اي نعم، هذا الكلام يعني ممكن يجي عليا يكبرني، لكن لا اخجل ان انا اقول انا كبرت، لان اللي انا بتكلم عليهم دول كبار وناس يعني زي ما بنقول اثبتوا نفسهم. دكتوره منار والدكتوره ساره والدكتوره هاله، فربنا دايما يجعله اسم نشط واسم ذكي واسم زي ما بنقول سمارت زي ما هو موجود في التايتل بتاعنا. يسعدني ان انا اقدم الدكتوره هدى فريد اللي هتعمل لنا برزنتيشن. التوك بتاعها التايتل Bridging the Gap Challenges and Smart Solution. دكتوره هدى فريد. اسفه معلش انا مركزه.
لا ولا
وان دايركشن. اتفضلي يا دكتوره هدى.
اوكي. السلام عليكم. طبعا انا بشكر كل اللي قائم على المؤتمر، مش بس السنه دي الصوت واصوات ايوه كده سامعيني. طبعا 11 سنه اللي احنا بنعمل فيها المؤتمر، كل سنه المؤتمر بيبقى فيه تجديد، فيعني انا بحب اشكر كل الناس القائمه على المؤتمر. وهحاول ان شاء الله التزم بقى بال 20 دقيقه. طيب النهارده هنتكلم عن الانتجريتد هيلث كير موديل. I will be talking in English because in honor of our professor Williams. So all of you know Am Ramadan. Allah yarham. He was a patient that we all loved. What was very specific for Am Ramadan is that he knew his patient journey. He knew who to see. He had a few physicians in order, plan A, plan B, plan C, and then he would call one of us, maybe another one, remind us of his case mix, his medications, and then he knew that we would either refer him to the hospital to be admitted, maybe some investigations and follow-up. So he knew his patient journey. On the other hand, I'm a professor. I have, I think, some sort of medical education. I have a network of physicians, but I don't have a clear patient journey. I have a lot of comorbidities. I don't have a focal person like Am Ramadan had. So the patient journey is very important. It helped him sustain good outcomes, I think, till the end of his life. And this is very important for integrated healthcare. If you could please enter in your mobiles or your browsers menti.com and then enter this code, we're going to have a small survey. We have two questions. I would like you to answer the first question only, and it's about what do you think your knowledge or idea about the catchment area of Ain Shams University hospitals, the percentage of patients that present from Cairo. Just enter menti.com and then you will have a place to enter the code 15884036. The QR code is not working. We tried it. Unfortunately, it's not working. So it's working? Okay, perfect. So maybe some mobiles and the others. So far, three of you think that 60 to 79% come from Cairo. We only have a few minutes because we have to continue the presentation, so if you could enter your input. The screen is black. It's not working. Thank you. It's not working here. مش شغال هنا. البرزنتيشن لا مش شغال. My speed is fixed. I'm sorry, I will have to look at the big one. So 11% think that 100% of the patients come from Cairo. 80 to 99% think that, 11% think that 80 to 99%, and 56%, the bigger percentage of you think that 60 to 79% come. Could you please close the screen? Go back to the presentation. Thank you. ايه؟ ما هو ما كانتش شغال كنت ببص للسكرين دي بس. So actually these are statistics from our hospitals, and as you can see only 60% of our patients come from Cairo, the rest come from other governorates. And what's impressive is that we actually have patients coming from 30 countries, not just from Egypt. These are where they're living in Egypt while they are in Egypt. But otherwise, we have 30 countries being treated in Ain Shams University hospitals. So again, could you please also enter the second question? You have 3 options. You can enter 3 keywords about how do you think we can have an efficient healthcare system, given the fact that if 60% of the patients only are coming from Cairo, and this is the percentage of patients without age distribution, if elderly patients present around 10% of the population, most probably they present a larger percentage of the ill that are coming to Ain Shams University. Thank you. So we have keywords like multidisciplinary, continuity, comprehensive, complicated, empathy, continuity of care. Are these your input? Okay. Rehabilitation, patients, affordable, integration, efficiency, communication. For your input. Now let's talk about how we can actually have an efficient healthcare system, have an integrated healthcare system. There are a few keywords. The first is value-based care, and I think I've talked about it several times. This type of care is focused on the patient outcomes. Having the balance between the outcomes of the patient, the quality of the healthcare service that we are delivering, and the cost. And this is all reflecting in what you have entered. Some people mentioned affordable, some people mentioned integration, and so on. The second keyword is patient-centered care. And this is something that we focus a lot in our departments. What does patient-centered care mean? It means that we put into consideration the needs, the preferences, the values of the patient. Another very important point that we gave Ramadan is empowering the patient. If the patient knows information about his disease, about his medications, about the red flags, then he can focus on how to manage and help you manage. And a lot of studies have said that. Empowering the patient has positive impact on the outcome. Again, I lost my screen. How does value-based care and patient-centered care fit into integrated care? So the WHO says that the organization, integrated care means the organization and management of health services so that people get what they need, when they need it, and that it is user-friendly and it achieves the desired results and provides the value for money. This is the value-based care. And then they added that integrated care should be centered on the needs of the individual, their families, and the communities. Here comes the patient-centeredness. So in short, integrated care is having value-based care with a patient-centered approach. in my opinion, when we try to implement this, each patient has this flask of services that helps provide the integrated care. So many people can have the same case mix, but because they have different needs, different values, I probably have to give a different type model of healthcare service. So one patient would, for example, have care at the physical clinic, and then he needs home care because they have a disability, it's difficult to move. And another would probably accept telemedicine and have the physical care and some telemedicine services. So filling this funnel with whatever services the patient needs is the way to have integrated healthcare. Now, the keyword technology in healthcare. How can we use technology in healthcare? In my opinion, it's not technology in healthcare. It's a little bit distorted. We should strike the healthcare part. It's technology for attaining integrated care. And I think I've said this several times. Don't use the technology for the wow of the technology. We use it for filling a gap. And according to this golden circle, you have to answer the question why. Why are you using this technology? If it's not fulfilling these 3 points, then don't use it. Another very important point regarding the use of technology, according to this model, using technology for integrated care has many levels. Sometimes when I talk about technology, what comes in mind of most of my colleagues is using telemedicine, and this is the technology that we're going to use. Actually, this is only at the level of the patient. So at the level of the patient, technology could be telemedicine, could be wearables, a lot of other technologies that can be used to improve his healthcare. And then you have the level of the healthcare provider. Just using electronic medical records can help with the outcome of the patient. Okay? Using an AI decision support system for those physicians that are in rural areas. And then we have the organizational level, at the level of the hospital, for example, having enough data to be able to take decisions. So maybe one of our projects is having a command center. Ain Shams University Hospitals has 3 campuses. The one at Demirdash, the one at Specialized Hospital, and the other at Abur. And all of them have ICUs. How can the CEO of the hospitals manage these ICUs if he does not have enough information? At this point of time, we should always have information about the number of beds, how many patients have been, the length of stay, for example, of the patients, and so on. So having a command center that has information about the medical information of the patient, information about the beds, information about infection control, and so on, is very important. Data-driven decisions is very important. And then we have technologies. I'm only giving examples. It's not just what I'm saying. These are only examples. And then we have technologies at the level of the healthcare system. So here in Egypt, one of the things that are being developed is an emergency operating center. This should be something national, and then it has many nodes, for example, in the hospitals. And we're trying to have one of them at the Demirdash Hospital. What does this make? It has a lot of information from the weather, information from infection control from the hospitals. It was very vital, for example, for something like COVID. And a lot of countries have these emergency operating centers. They have to be integrated. The central part, for example, in the ministry, and then the other parts. Another very important point is we talked about technology filling a gap, and then we're talking about technology in low and middle income countries. I cannot take the technology as it is, copy-paste from the north, and then try to implement it here. So for example, I'll just give you a small example. The command center needs this piece of equipment that takes information from the ventilators, from the monitors, and so on, and then dumps it in this dashboard where I can see all the patients together. This small piece of equipment, if you are trying to buy it from GE or from Philips, you would have to spend around 6,000 per patient as upfront cost, and then there's a monthly cost, and this is in US dollars. This is not affordable. It's much cheaper to have my physicians, 2-3 physicians running in the ICUs and caring for the patients. So trying to take the technology, the idea, but twisting it and tweaking it so that it can be applicable in the low and middle income countries and can be sustainable, this is very important. So we don't take it as it is. Sometimes it is the piece of equipment that is being developed. Sometimes it is the workflow that we are trying to adjust to make sure that it is applicable and sustainable in our countries. Now, how does this apply and how have we applied this at our hospitals? So we have a group of pilot studies for continuity of care, closing the circle of continuity of care for the patients. We've piloted a lot, and one of them was very successful. Dr. Noura will be talking about it at the end of the day. And this was a package of services with follow-up of patients, dementia patients, and their caregivers. It was very successful, and this gave us the push or the kickoff to be able to support other geriatric patients at the geriatrics hospital. A package called Sohba, which translates into company, and it should be providing all types of services, as we said, filling the funnel for the patient with whatever types of services that they need. So if they need just acute care, physical presence at the hospital, if they need telemedicine, if they need community care like Professor Williams will be talking about later on, this is very important. So our patients have a lot of comorbidities. If I provide this patient with the option of having telemedicine consultations and also telling them more information and empowering them about their disease, their medications, and the red flags that they have to take care of, and then also tell them that you have, for example, scheduled physical visits or when to come to the clinic versus when to just use telemedicine. This is just one type of package that can be provided for the patient. Maybe another would need home care. This would definitely prevent the patient or decrease the repeated ER visits, the coming to our clinics, the risk of having infection, waiting long hours at the clinic. So I've had this acute disc prolapse. It's very difficult if you have a problem and then you have to wait for hours just waiting in line for a clinic or for an X-ray or an MRI or something like that. We have to take care of these. This is where the patient satisfaction comes. And Dr. Noura will tell you specifically about these outcomes, very positive outcomes from her study. The first thing that we've done is a retrograde survey with the patients that were admitted at our hospital. And we found that 91.5% of the patients would prefer to follow up with our physicians that have treated them at the hospital. 93% of them said that they are willing to pay from their pockets for telemedicine follow-up. This is being done in the different specialties. For example, there's this initiative with Sanofi for 6 subspecialties, and of course 5 of them are already part of our comorbidities at the geriatrics hospital. This is totally free for the patients. And so our takeaway message is value-based care, patient-centered, for integrated healthcare. Use the technology if it is helping you reach this integrated healthcare, and take into consideration that not all technologies, not all workflows can be taken copy-paste from the global north to our countries to be implemented. Thank you very much.
شكرا دكتوره هدى على البرزنتيشن، وزي ما حضرتك عرضتي it is a very يعني advanced issue to care for the patient at home. It is actually practiced nowadays with telemedicine belong to Department of Neurology. It is the same belong to them or another approach or another initiative لصحتك في بيتك.
لا هو حضرتك هو اصلا التيلي ميديسن مش تبع النيورولوجي بس، هو التيلي ميديسن اللي عملوه اشخاص الاول هو دكتوره هدى فريد اللي اسسته، هي ودكتور تامر، هو نيورولوجي وجينيتكس، ابتديناهم الاثنين مع بعض كده التيلي ميديسن، وبعد كده الاكتيفيتيز بقت تبع الفيرشن هوسبيتال بقى اللي برضه هدى فيها، يعني بقت تبع الفيرشن هوسبيتال مع كل الانشطه اللي بيعملوها، عاملين انشطه عندنا في الكليه كمان، يعني بيعملوا فحص شامل للموظفين كلهم في الكليه.
لا أنا بالنسبة لصحتك في بيتك it is an initiative belong to telemedicine or another initiative. It is belong to virtual hospital.
virtual telemedicine يعني من 2016 هي انشئت مستشفى وليها لائحه في المستشفيات.
ايوه ده اكريديتد كمان، يعني الدكتوره ماهي كانت قالت ان هي اكريديتد امريكان اكريديتيشن.
هو الهدف يعني improving healthcare services مش التليميديسن في حد ذاته. طبعا التليميديسن يعني انتشر قوي لان احنا بدانا وقت الكوفيد استخدمناه كتير فالناس عرفته اكتر، بس هو الهدف ان انا احسن الهيلث كير سيرفيسز بالتليميديسن اور without. فمنها بقى one of the initiatives زي صحة في بيتك، another initiative هي صحبة في المسنين. ففي initiative تاني في الاورام لمتابعه المرضى اللي عندهم complications من الكيموثيرابي اللي بياخدوه. ففي كذا
expansion in different
لان
approaches.
المودلز مختلفه، يعني كل تخصص وكل حاجه عايزين نبحثها محتاجه ورك فلو كامل وهو متكامل. طبعا احنا الهوم كير بنحاول امبلمنت طبعا، بس لسه يعني نوت توتال امبلمنت، بس هو في دماغنا لان هو لازم انا اوفر لكل عيان الحاجه اللي تبقى مناسبه.
شكرا. في اسئله من القاعه؟ في اي اسئله؟ شكرا يا دكتوره هدى، شكرا.
بشكر الدكتوره هدى فريد على المحاضره وعلى النشاط. يعني الدكتوره هدى زي ما قلت لحضرتك من المؤسسين التيلي ميديسن والفيرتشوال هوسبيتال، عامله شغل جامد مش بس على مستوى مصر، هو الفيرتشوال هوسبيتال عامله شغل جامد قوي دكتوره عائشه كمان على مستوى الدول الافريقيه. يعني هم هدى صلحي عليا كده لو في حاجه، هم تقريبا عملوا دبلومه بتاعت الاوفثالمولوجي في احد الصومال ولا في الصومال، في مكان ما فيش اصلا في اي حد اوفثالمولوجي خالص، دربوا ناس وعملوا لهم ماستر هناك ودربوهم، وعملوا استابلش اي سي يو سيرفيسز فين؟ برضه في الصومال. مش سامعينك.
يعني هو زي ما قلت لحضرتك احنا بنشتغل في جلوبال ساوث مش في مصر بس، ففي بعض البروجكتس تمت في الصومال، في حاجات في نيجيريا. الهدف برضه ان انا احسن هيلث كير سيرفيس او ابدا هيلث كير سيرفيس مش موجود. فيعني فور اكزامبل في الصومال في ايست افريكا يونيفرستي ما كانش في اي سي يو خالص في مكان في حوالي 1,000,000 شخص، ما عندهمش ولا سرير اي سي يو ولا انتنسيف. فاحنا بنتدربنا، رحنا هناك دربناهم وعملنا الاي سي يو زي ما حضرتك سكراتش، اكسجين، سولار بانلز، كل حاجه. حاجه ثانيه مثلا في نيجيريا هم عندهم ناس بس بتوع سيرجري بس عايزين يستخدموا خدمه، عايزين يستخدموا المناظير، ما بيعرفوش يستخدموا المناظير، فبرضه نفس الكلام بندربهم ندربهم نشوف الاجهزه اللي محتاجينها. فهي الهدف تحسين او توفير هيلث كير سيرفيس فاليو بيست نيشن. في حاجات بقى تاني ماديسن، في حاجات تريننج اونلاين، في تريننج هم كانوا هنا مصر قعدوا 3 شهور دربوا على باتشز، يعني دربوا 20 شخص. هو اكشلي اول مشروع كان مع نفس ايست افريكا في 2016، كانوا عايزين نيورولوجي وكارديولوجي كلينكس في نفس المدينه اللي هي بوساسو. تاني بروجكت هو الاي سي يو، ده مشروع بمليون $500,000 في اليو اس اي، في يو ان دي بي، سوري، في ال اي، في مركز عبد البنك الاسلامي للتنميه. فهي مشاريع كلها هدفها ان انا احسن الخدمه للناس.
بسم الله الرحمن الرحيم. اولا انا برحب بدكتوره عائشه استاذتي، وحضرتك مش بس علمتينا، انت مؤسسين الاسم، حضرتك ودكتوره هدى فهيم، وليكي افضل علينا كلنا طبعا، واحنا سعداء ان حضرتك دايما تبقي معانا. احنا لينا الشرف ولينا ربنا يبارك في حضرتك، احنا لينا الشرف، احنا لينا الشرف ان حضرتك تبقي موجوده معانا، واحنا دكتوره هدى، وربنا يبارك فيكم دايما يا رب. وبرحب بدكتوره منار زميلتي طبعا رئيسه الاسم. هدى انت فاجئتيني ان ده المؤتمر 11، الواحد كان ناسي، افتكرت واحنا قاعدين اول مؤتمر خالص عملناه دكتوره عائشه ما كانش في بقى لا ايرس ولا حد، وكان اشتغلنا شغل بالورقه والقلم ونتعلم. احنا عمرنا ما كنا عملنا انترناشونال كونفرنس وكنا بنتعلم، يعني كنا بنفرش الورق انا ومنار، وكان معانا سلمى وولاء، نقعد بقى نعمل خطط ومين هيجي ومين مين والاماكن فين ونحجز ازاي وكده، كان كله فروم سكراتش. بالظبط. فالله يعني يرحم الجميع، واساتذتنا طبعا يعني هم افضل علينا واحد واحد، يرحم الجميع يعني. برحب بسكند سبيكر دكتور عبد الرزاق ابيض، كونسلتنت تيرنال ميديسن. ودكتور عبد الرزاق طبعا لينا شغل معاه كتير على مدى سنوات، هو شيرمان اوف ذا اكاديمي اوف ميدل ايست اكاديمي فور ايج اند ايجينج. لسه كنا عندنا ورك شوب امبارح معاه، كان واحد السيشنز اللي بنعملها، ثالث سيشن كنا عملناها في مصر عن الديمنشيا، وكان معانا بروفيسورز من يونيفرسيتي اوف ريدنج في اليو كي، وكانت مثمره، سيشن مثمره نعمل ان شاء الله نكررها. التايتل بتاع المحاضره بتاع الدكتور عبد الرزاق ابيض سمارت تكنولوجيز فور ديمنشيا AI's role in diagnosis and support. اتفضل يا فندم.
Thank you very much for the welcome note. It's always a pleasure to be in Cairo, in Egypt. It's almost like second home. It's maybe my 15 visits to Egypt. Actually, my grandmother is Egyptian, so I have root in Egypt. So, as Prof. Hala was mentioning, we are going to talk a little bit about the use of artificial intelligence in dementia, whether we can use it or not, whether it's useful or not, whether the technology is good and cheap and affordable or not. Hala, why we worry about dementia? We worry about dementia because, as you know, every 3 seconds there is a new case of dementia. So we are worried that things will escalate more and more. And as you know, by 2050, we have almost like 2 billion people above the age of 60. Not only that, with the increase of disability, we have more and more demented cases, and those cases will particularly reside in developing countries. So we are expecting by 2050 to have almost like 150 million demented patients. So the need is there. And the alarming statistic showing that almost 70% of the cases, demented cases, will be in developing country, in our part of the world. Hala, what are the challenges that we face? It's very clear that we have rising costs, we have aging population, we have increase in the dependency ratio. We don't have enough doctors. A lot of countries, as it was mentioned, we are resorting to telemedicine because we don't have enough doctors. And there is an increasing demand for personalized care as the population is aging. Is artificial intelligence the solution? This is important to answer. And as you know, whether we like it or not, artificial intelligence and technology is invading the healthcare sector and eventually will take over more, maybe. So can AI cut cost effective? Can improve work efficiency? Can it replace the work of the doctor? And this is the big worry of a lot of physicians. And can lead to standardization of treatment? And can we eventually have artificial intelligence doctors or not? And this is important. Hala, as you know, right now, artificial intelligence in health help in early detection of ailment, improve decision making, help in treatment, expanded access to medical services, end-of-life care, checking health through wearable, giving a superior experience, and a lot of associated care. What are the challenges in dementia care? A lot of challenges. There are symptom overlaps. We have a lot of diagnostic delay and a lot of caregiver strains and a lot of financial burdens. Almost 50% of demented patients are not diagnosed or are not diagnosed very early. And developing countries, maybe it reaches 70%. There is a lot of personalized need care in dementia, and there are lack of resources and a lot of care burden problems. According to Alzheimer's Disease International, early detection of dementia will be very important in the management of patients. And this is a diagnosis gap that we are talking about. In developed countries, almost 50% of demented patients are not diagnosed. Not only that, there is something called the vanishing 50%. Out of those diagnosed, almost 50% not diagnosed, 50% not treated, and those that are treated, they are not compliant with medication. The challenges for the caregiver, the first challenge is for the caregiver to recognize that their elderly has a dementia, getting a diagnosis, finding helps, and dealing with the behavior disturbances, and considering possibility of nursing home placement. What are the role of artificial intelligence in diagnosis? Artificial intelligence is trying to revolutionize the way we deal with dementia and trying to help us in early diagnosis of dementia, and usually using deep learning technique and very difficult technique to reach final decisions. So it's helping us with data analysis. It analyzes large data set for early dementia detection and diagnosis. There is a lot of predictive model, what's going to happen with the patient once diagnosed. Image recognition, a lot of studies on MRI and PET scan. And patient monitoring is of importance. This is a recent study in 2024 in Nature, and this shows you the complexity of the model in artificial intelligence, whereby we integrate demographic, health history, physical, neurological test, MRI scan, and all of those go into different type of deep learning and machine learning until you get the output. So your job is to input all this information, and the artificial intelligence will tell you whether the patient has dementia or not. And this is another thing. A lot of MRI in different centers in the world and PET scan are relying on artificial intelligence now for saying what is the pattern of dementia. And this is recent voice analysis. Using voice, we can tell whether the patient may have dementia or not. And this is very easy to be applied. But again, you have to train the machine on voice analysis. This is another thing. Retina funding, as you know, changes in the retina may indicate early dementia of the patient. And again, through artificial intelligence, they took a bank from UK bank, people above the age of 60 with Alzheimer, with no Alzheimer, and they fed them into the program, machine learning, and they came with algorithm and outcome of different possibilities: Alzheimer's disease, stages, normal patients. So what artificial intelligence is help as well, tailor the treatment of the patient, decide what type of treatment is best for the patient. Nutritional recommendations, that was, we were talking about it yesterday, behavioral insight, and routine adaptation for the patient. Artificial intelligence can have 85% prediction of cognitive decline. It can forecast in 92% whether the caregiver will end up in burns or not, anticipating medication non-adherence in 80% and 80% prediction of hospitalizations. So, early detection AI system is already in existence in several countries. We have, I think, as well, we can resort to personalized intervention platform. And this is a mobile application called RAS. If you put it on your mobile, put RAS, and you'll find caregiver support for the caregiver, advice for caregiver. As far as ongoing care, as you know, we have the caregiver burden, and artificial intelligence is there to help the caregiver in several issues, mainly in medication reminders, behavior monitoring, companion bots, daily activities assistance, and others. So those are the major things that can help the caregiver. Task automation, we have visual assistance, we have as well remote monitoring, we have furthermore caregiver empowerment, and finally daily care technology. Again, smart home is another thing developed in a lot of developing countries. And here we have a lot of activities, including remote monitoring, digital communication, emergency alert, and cognitive aids of the patient. Again, smart home technology trying to make the home safer for the elderly if they are living independent. And this is a project in Australia whereby the Florence project, they are trying to do a lot of easy entertainment for the elderly living at home alone or with the caregiver. So this is how sometimes technology helps the problem faced. A lot of time your elderly is left alone. So what we can do, we are offering to them some now robotic help, and this will improve the patient engagement and interaction level. A number of robots been in existence for a while, and these are different type of robots that we are not going to talk about them in details, but the robot may help as helping the patient, presenting him with food, with coffee, entertainment, reading for him, making him his companion, psychological help, monitoring and safety, information education games that will entertain the patient, cognitive training, and it has very simplified menu to access service and help him with reading as well. This is one of the robot, HeroShan, is a soft robot that is showing research believes that interacting with HeroShan reduces stress in people with dementia. And this is very important. What are the future direction? AI in dementia is there, and it will improve the way we diagnose the disease, and it will improve the way we think about the patient and personalized treatment for the patient. We have already AI-powered brain imaging that will improve more and more. Predictive analytic for disease progression is there. Personalized treatment recommendation is there. And cognitive assistant for researcher on dementia is already being developed. In conclusion, this is where we are. Again, there are transformative for AI potential, improved diagnostic accuracy, personalized patient support, accessible data management, and enhancing caregiver training and addressing ethical issues as well and challenges. And thank you for listening.
Thank you, Dr. Abiad, for this precise information. Though الهيرو شان دي شكلها يخوف شويه. بتوع الديمنشيا هيحضنوها ازاي دي؟ انا خفت منها. بس واضح ان هي في طبعا اكيد البروجرس والانفولف بتاعت الاي اي في حاجات كتير وكمان الديمنشيا ومع الانكريز اللي زي ما حضرتك قلت السيرفيسز فور dementia is very difficult currently with the increasing number of demented patients. So we need help and AI the best helper now. Any questions for Dr. Abiad? Thank you so much.
At the beginning of your presentation, you ask about it could be replace a doctor. At the beginning of the presentation, you ask questions. It could be replace a doctor.
This is the most thing that worried doctor actually. And the answer, it will not replace doctors, but doctor has to know very well artificial intelligence.
It helps the doctor.
Yeah, it helps the doctor. It helps the doctor, and doctor has to be well trained in artificial intelligence in the future. 10 years down the line, people need to know, physicians need to know more genetics, more artificial intelligence, because both genomic and artificial intelligence is changing the game in medicine.
Research and diagnosis.
Yeah.
But to give care for elderly with dementia, I think emotional factor is very important. So we need a doctor at any time. We need
the personal touch will be there. Sure. Thank you.
في البداية أحب أشكر الأساتذة الأستاذة الدكتورة منار والأستاذة الدكتورة هالة سويد والأستاذة الدكتورة سارة على دعوتي وأقول لهم كل سنة وأنتم طيبين وأشكركم لأنكم لسه فاكرين الناس اللي درسوكم زمان جدا. أنا والدكتورة عيشة اشتركنا في البدايات خالص وإحنا مبسوطين إن إحنا معاكم بصراحة النهاردة. بنشوف النتيجة يعني البذور بقت نباتات كبيرة وأشجار وريفة. الحمد لله الحمد لله تعيشوا كل سنة إن شاء الله. دلوقتي أحب أقدم الدكتورة هدى طارق اللي هي مدرس في قسم طب وصحة المسنين. هتتكلم على reducing hospital admission through remote monitoring global insights.
Assalamu alaikum, dear professors. So we are talking today about reducing hospital admission through remote monitoring and its global insights. So let's start with this story. This is Mrs. Sally. She's 74 years old and she's living alone. She also has congestive heart failure. Last year, she was hospitalized 5 times. Every time she presents late that she has to be placed in the ICU. That really affected her physically and mentally. After the last admission, however, her doctors tried something new. Again, this is Mrs. Sally, 11 months later. and she hasn't been in the hospital through 11 months. So what happened? So let's start with talking about hospital readmissions. Why hospital readmissions are of global concern? A common measure of quality of care has significant economic and social consequences. The rates of the hospital 30-day readmission is nearly 15% in all Medicare patients. So why? Because of the poor post-discharge care, lack of medication adherence, cognitive decline, limited mobility, and inadequate patient education. And this pressures the system with high costs, increased patient burden, reduced quality of life, and increased the risk of complication and mortality, of course. As we are facing an aging population, we are facing higher hospitalization rates and higher readmission rates. Nowadays, Medicare set policies to set penalties for hospitals who have higher admission rates. Most efforts to reduce readmissions have focused on improving in-hospital patient education and discharge planning, as well as improving in-hospital patient education and discharge planning, as well as increasing post-discharge follow-up and monitoring with various interventions, including structured telephone calls, telemonitoring, home or clinic visits occurring in the post-discharge period. Telemedicine has been shown to reduce emergency department visits and hospitalizations. Remote monitoring can lead to development of a home safety environment that could help elderly people live independently in their homes. So, what is remote patient monitoring? It's a strategy of telemedicine that offers a way for clinicians to observe patients' physiological parameters remotely and to intervene if abnormalities appear. Common technologies used are wearable devices, and we have more invasive technologies like pacemakers, implantable cardioverter defibrillators. So how does it work? As we observe this graph, this is a patient home setting, and this is a hospital center. Telemedicine system, it comprises of a web-based application and infrastructure that includes healthcare consumers, data center, interface engines, and healthcare providers. This system collects the patient information through questionnaires about the history and the symptoms, and also vital signals through the sensors. It pre-processes the data and sends it to the external service provider that will analyze the data and then forward it to the physician. The geriatrician can then transmit a feedback in the form of advice or change in the therapeutic protocol for the patient. So, can telemedicine reduce readmissions? Such technology has altered healthcare delivery, increased access, quality, and cost effectiveness as they provide timely interventions and improve patient engagement and outcomes. Despite technological difficulties, payment rules, and patient apprehension, telemedicine is becoming an increasingly important tool in post-discharge treatment plan. So how remote patient monitoring reduce hospital readmissions? It provides personalized care, remote consultations, early detection of new symptoms, improved medication adherence by setting alarms for the patients, identify and monitor high-risk patients, improve transitional care management, and enhance patient understanding for post-discharge instructions. So let's see some examples of remote monitoring devices, either wearable, patch, or Bluetooth and cellular devices. So this is not a normal blood pressure measuring device. This is connected to a system via a wireless system, where when the patient had to measure while in home his blood pressure, doctors know the blood pressure. This is a scale also connected to the system, especially for congestive heart failure patients. It's very important, or any patient like renal or chronic liver disease patients. Also, this is glucose monitoring device that is connected to the system. And of course, this is the continuous glucose monitoring patch. This is a wearable device used mainly for sleep problem monitoring instead of the patient having been to the sleep lab and have a bunch of wires attached to him. And this is good for the patient in the home setting, and it will diagnose sleep problems. This is a pulse oximeter, but also Bluetooth connected to the system. This is a wearable device for epileptic attack monitoring. It predicts the epileptic attack and records it. Also, this is a digitalized inhaler. It is connected to a mobile application. It is used to monitor the patient condition, and maybe the doctor will tell him to increase the number of puffs or something. This is amazing. This is an ECG attached to a shirt, and all the patient has to do is to wear this shirt while he's at home, and the doctor will have a full ECG. This is a Holter patch. This records ECG for 14 days while the patient is at home. This is amazing for geriatric patients and ICU patients also. This is an orientation and activity pattern patch. It records the pressure areas and pressure sites in the patient, so it will prevent pressure ulcers, as we see here. It will prevent the pressure points from developing an ulcer. Also, it monitors vital data like heart rate, respiratory rate, and so on. This is a temperature continuous monitoring patch. So, benefits of remote monitoring of the patient. As we said, continuous monitoring increases the patient confidence, efficient communication, early detection of deterioration, visualization of the long-term health trends to determine ideal treatment plan, and improve patient education. Some challenges and limitations we are facing still. Some physicians, according to a study was done, physicians can observe it as a workload, as they have to do a lot online. Patients and anxiety, because we are always giving them alarms and notifications about their health condition, so somehow some patients get anxious. Limited trust of technology and problem as we are approaching geriatric population. Technology access problems and adherence to monitoring programs itself. Financial responsibility, of course, it's not clear yet, and privacy concerns. So, back to Mrs. Sally. Mrs. Sally's doctor tried to give her a remote monitoring, enroll her in a remote monitoring program and give her an iPad and a digital scale and a blood pressure monitor and oximeter to determine the oxygen levels in her blood, and handled her a handheld EKG device. So her computer dings every morning and reminds her to check her vital signs and record them. Also reminds her of her medication, so she became more adherent, and she uses a touch screen, simple touch screen, to answer also a few questions about how she's doing. So results are wisely transmitted to the hospital, and doctors observe danger signs if there is weight gain or something and worsening, and then the computer give her notification to the patient or to the nurse who is in charge. So Mrs. Sally seems to love this equipment. She doesn't have to go to the hospital every time she feels something new, and then she's more compliant, and that's why she has been compensated for almost a year. So let's observe some global insights and studies that was done. So a study was published in Geisinger Health Plan telemonitoring in US. They implemented a telemonitoring program for heart failure patients, resulting in 23% reduction in hospital readmissions. They used Bluetooth scales and interactive voice response system to report daily health data. University of Pittsburgh Medical Center in the US, the remote patient monitoring program for congestive heart failure led to 74% reduction in 90-day hospital readmissions. They also received some kits and educational material and were leading to more compliance. In the East, National Taiwan University Hospital, Yunlin branch, Taiwan, they established an iCare telehealth smart discharge care network to monitor high-risk discharge patients. And this network involved case managers coordinating home monitoring for 2 to 8 weeks in the patients inputting and uploading health data through home monitoring devices. Shanghai General Hospital and Philips Telehealth Program, Singapore, the program provided patients with devices to monitor vital signs which were transmitted to healthcare professionals for remote assistance, and results indicated improved self-care compliance, enhanced patient confidence, and reduction in the heart rate failure-related hospital readmissions. Ontario Telemedicine, in the US, targeting patients with chronic obstructive pulmonary disease and congestive heart failure, and this achieved over 60% reduction in the hospital admission. This randomized control trial also used a similar system, and it aimed to evaluate the feasibility and effectiveness of a 12-month remote monitoring program in preventing rehospitalization. During a 12-month follow-up, we had 40% in the intervention group who were using this software with at least one unplanned hospitalization versus the control group who had 48.7% hospitalization. This clinical trial also aimed to assess whether home 30-day telemonitoring after discharge for the patients would reduce readmissions or mortality. And here we have, in 30 days, 18% in the intervention group had lower risk of readmission or death. Also, 8.6% emergency department visits compared to 23.7% and 14%. So in conclusion, remote patient monitoring is an effective strategy to reduce hospital readmission, especially among elderly patients with chronic conditions, by enabling early intervention, improving medication adherence, and offering continuous care. Remote patient monitoring promotes healthier aging and better outcomes. With ongoing technological advancements and broader adoption, remote patient monitoring has the potential to become standard part of elderly care, further reducing hospital readmission and improving quality of life. Last but not least, let me introduce IMRAM. IMRAM is an electronic medical record adoption model. This is concerned with accreditation of the digital system and digitalization. So one of its terms and condition now is having remote patient monitoring installed within the hospital and even connected to the HIS. So it's not becoming something luxurious or accessory, it's coming core and fundamental part of the digitalization of the healthcare. Thank you.
شكرا دكتورة هدى على البرزنتيشن. في حد عايز يسأل حاجة أو يستفسر؟
اولا بشكرك يا هدى، presentation كويسه جدا. Thanks for your presentation. You didn't mention the drawbacks of home monitoring. Missed cases exposed to danger, misdiagnoses. I would wonder if you
يعني هي لسه حاجة under examination، لسه يعني number of studies that is published little. No one is talking about the drawbacks and the missed cases yet. They are talking about how it improved the system, how it improved the health status of the patient, how it decreased the readmission rates, and they are more concerned about the security of the data, who is willing to finance this, is the Medicare and the Medicaid are willing to perform this or not.
هي بس انا كنت بلفت نظر ان فكره يعني قلت لي مونيتورنج ممكن تو ميس بيشنت، يعني ممكن واحد عيان واحد بس الترانسفورميشن بتاعت الريزلتس بتاعته ما تكونش اكيوريت، لان الكلينيكال دايجنوز ستيل برضو مهم، يعني ان الدكتور بيبقى له نظره غير الفيتال داتا غير الاكويبمنتس والميجرمنتس. It's good بس معاك يا هاله بس
short-term follow-up بالظبط كده. Some hospitals are trying to establish remote patient monitoring within the wards, يعني to test it, يعني في السعوديه مثلا بداوا ان هم يعملوا ريموت بيشنت مونيتورنج بس within the hospital center ل cardiac surgery hospital يعني.
شكرا. Thank you.
Thank you.
Last but not least, Professor William Hills will going to introduce us the big psychological integrated care for optimal aging and emerging model in the United States. Professor William is Professor of Psychology in Coastal Carolina University, USA.
Thank you. I'm delighted to be here with you today. I want to talk about a couple of things. One is patient-centered, but one is, I think, a paradigm shift for where I think a lot of the emphasis is these days and where I think it might be going as we move toward the future. The whole concept of optimal aging has become very important in the U.S. over the last few years, and there's an emerging model that looks at this. This is also known as successful aging. I like the term optimal a little bit better, but it offers a new perspective. And I guess why is this new perspective needed? I don't think our approaches to healthcare are going to be sustainable with global aging. We're going to have to see some modifications as we move forward. We're redefining aging. A lot of our concepts of aging are based in the research that began, back in the mid-century, but a lot of that information that was earlier released was fairly negative. And if you think about it a little bit, when you're studying aging processes, if something improves, okay, that's fine. If it stays the same, that's okay too. But if something shows decline, that will end up causing problems. And so that's where the research was focused largely on illness and the kinds of problems that we would see. So a lot of that early research produced the ageism that we see in the world today. It's certainly highly prevalent in the United States. And in fact, aging and disease were often linked. And so when people thought of getting older, they thought of disease, and they thought, well, aging is a disease. But we know, in fact, that, right, we're moving beyond that. But that ageism persists today, and despite a lot of research that it doesn't support that view. A big boost came around the 1950s or so in the U.S. with the longitudinal studies. For example, the Duke studies of what are called of normal aging now came along, and they were prompted by the baby boom generation. Following World War II, there were a lot of people that looked ahead and said, oh my gosh, we have all these babies. They're going to grow up one day, and they're going to move through society. They're going to move through the healthcare system. And in fact, they're going to change everything that we understand about aging. And in fact, that's what's happening right now. They predicted accurately a lot of the healthcare problems that we're having today, and the lack of healthcare professionals for the specialized areas of concern. The overall themes of these studies were important. Of course, we understood that longitudinal designs are necessary to study aging, and that the multidisciplinary team is the best type of approach. The biopsychosocial perspective then began to prevail. Also, though they showed in the absence of disease, there is still progressive decline. I mean, aging does involve some changes, of course, but there is a lot of variability among older adults. And in fact, a lot of the psychological and social resources that we employ as we age are stable until very late in life. Now, the longitudinal studies were fairly innovative in the 50s. The cross-sectional data had tended to show decline. But these were major studies that looked at the normal aging process. And so what we saw is a new conception of age. Rather than age and disease being synonymous, we began to see normal aging independent of disease. Yes, disease occurs more often in late life, but it doesn't occur for everyone. The conversation was elevated in roughly the 1990s by this book that was very popular in the United States. It became a bestseller called Successful Aging. It was based in a MacArthur Grant Foundation, and you see that the subtitle shows you how the lifestyle choices you make now, more than heredity, determine your health and vitality, right? So the new concept beyond age is synonymous with disease, normal aging then, right? Non-pathological aging. Now we've got successful aging or optimal aging, little or no loss of function as we age. And the environment, of course, is very important in that. According to Rowan Kahn, activity was the key to this, right? Active avoidance of disease, right, in the medical world. In the psychological world, active engagement and stimulating activities. And then in the social world, too, active integration in society. But activity being the key to all of this. Now, this took hold in the literature, and of course, everybody began talking about this and studying this. Some said, yes, this is just what we've needed all along, a new conception. Others said, well, what about the special populations? There's cultural bias, there's all sorts of things. Maybe the word successful isn't what we need. And so a lot of people began introducing additional terms: optimal aging, healthy aging, adaptive aging, active aging, and every psychological construct you can imagine was studied in relation to this idea of successful or optimal aging. But by talking about this, what Rowan Kahn really did was stimulate the conversation. By studying what was right about aging, it gave us a new perspective. So instead of just simply studying what's wrong, why don't we study what's right, right? And so what they were doing, of course, is looking at the factors that promote successful or optimal aging. And, well, we understand now we need to focus on the whole individual. We need to know the biological and medical condition of the person, of course, but we need to look at psychological and social aspects of their well-being also. Now, the early debate was on disengagement versus activity. Disengagement, there's a gradual mutual withdrawal between the individual and society. People get old, they should withdraw, right? And they should get out of the way, you might say. It's the young people's turn. You've had your turn. But as we saw more and more people aging, and we all know what those numbers look like, a lot of people wanted to remain active. They thought it was important to maintain their activity levels, their roles, their involvement in the various aspects of their lives. And we began to understand the withdrawal isn't a natural process. It's something that traditional societies have forced on people. So, for example, retirement isn't written in stone. That can change, right? We can change the age of retirement. Well, how about acceptance of health problems? People began to understand that, well, I don't have to live like this. I can do something about this. And that was a big step forward to understand that we're more in control than we might think. I was fascinated by the earlier presentations. The telemonitoring is very big because it gives us some control, and we can learn how to, excuse the term, game the system. We can learn how to look at the results of these monitoring systems and then modify our behavior to go in the positive direction. It's off my topic, but I'm well aware of some studies there that it's just fascinating. But here's an unusual question. Do we want to live a long time? Here's my mother. I like to show her a picture. Everyone said all of my life that I looked like my mother. And now I'm going, oh boy, good. She died at almost 101, 2 weeks shy of her 101st birthday, died in her bed. So she was healthy all of her life. And so I'm going, okay, that's good because we know something about genetics and longevity. So I'm thinking maybe that's a good thing. Mm-hmm. So, but when we begin to really think about this with our current system, Is aging successfully possible? Is it desirable? When we begin really focusing on extending life expectancy into the later years, well, Professor Paul Baltes, very famous person in the gerontology world, said maybe we're just, reducing the opportunities of an increasing number of people to live and die in dignity, because we're going to have more dementia. We're going to have more of these kinds of problems. And we're all very familiar with these numbers. Look at the rate of dementia, and of course, Alzheimer's being the leading cause of that. But we know that this is happening on a worldwide scale, and it's happening, and I tell my students, on their watch, on our watch. It's happening now, and it's happening very rapidly toward our future. We know our healthcare is in transition. The numbers are really remarkable if you look. It just above 50 million, 55 million now, headed quickly up towards the 82 million by 2030, and then that number doubles by 2050. I mean, so the numbers are just getting astronomical when you think about what this means on a global scale. And the cost of this are incredible too. Look at the cost, up to over $2 trillion by 2030, and this is in USD. A lot of this, of course, is the informal care cost, right? Because that's where most of the care is taking place today and will need to take place in the future. This is mostly low-tech supportive services provided by family, provided friends who are largely unpaid and really not trained or educated for this, but who can learn to do a lot of this. And in fact, we know that most of it is provided as informal care in the home setting. And most 90-year-olds, in fact, require some care of this type now. So, this is a global dilemma, right? Some of you may recognize this was a famous television show in the United States. And Dr. Spock, right, asked the question, I guess, what happens when we have some medical advances? And I ask my students, do you think there'll be medical advances by 2050? Yes, right? But what happens when we cure cancer? Think of the number of people that we'll have in the world, and are we just eliminating cancer but destining more people to have dementing conditions in late life or Alzheimer's, because the risk does go up considerably for some of those conditions as well. Well, the new model in the U.S. includes this term behavioral health, and we're using this rather than mental health. Right? Behavioral health encompasses prevention, intervention, and recovery from mental health and substance use conditions. We include that in, of course, because that's a big issue in the United States. And healthcare in the United States is in transition now to include integration of behavioral health into primary care. Now, this has become the preferred term because of the stigma associated with the concept of mental health. Anyone my age or older recognizes that mental health tended to be crazy, right? Or it tended to have a different concept, a different definition than what our young people today understand mental health to include. But importantly for me as a psychologist, this acknowledges behavioral involvement in our health care and in our mental health care. There's an equal emphasis on health and wellness, and it includes the possibility of behavior change. And that's the important point here. Now, the integrated models are a team-based approach employing a biopsychosocial approach, right? We need everybody. We need the physicians, we need the mental health folks, we need the people that work in the communities to care for social aspects. And this isn't a single model, right? Yet all of these work together in an integrated fashion. Now, it is under the direction of the physician. That's understood by law. There's always a medical director overseeing the patient care, but also often with relatively equal status on the teams now are people with complementary skill sets. They're trained and they're educated to do things that the physicians are not trained and educated to do. For example, nurses, physician's assistants, nurse practitioners, behavioral health providers, social workers, community health workers, dentists, others too fit into this category. So again, it's not a single model. There's a team of providers. It's understood that the physicians have to be convinced that this is a workable model, right? But increasingly that's happening because we have more and more data showing the outcomes, showing the efficacy of these new integrated models, right? And so if a physician has a practice and that practice is doing some good and working for a long time, why should it be modified? Becomes the central issue. Now, the behavioral health addition to this can provide additional information now with the portals we have and the sharing of documents. Everybody has access to the same information. So a person might receive a referral to some other kind of service. In the past, it wasn't possible for these referrals to occur in a smooth fashion. I mean, the physician may say, well, the person needs a mental health referral, but that system is unwieldy and it's hard to navigate that without special knowledge. And so now it's sort of a one-stop shop, if you will. The integrated care means everybody has access and the referrals occur very quickly. Also, though, too, the individual can be seen in a specialized fashion before the physician ever sees the person. So now the person has been assessed for, let's say, depression, or they've been assessed for other conditions, and now the physician has that knowledge coming in to the actual interview process and can incorporate that into the diagnostic and therapeutic process. There are a lot of behavioral issues now empirically linked to medical outcomes. We know that. There's a lot of literature saying that if someone has depression, it affects the medical outcome, the whole process really, but the medical outcomes of treatment. Anxiety, elder abuse, things that are part of our communities. If someone is subject to elder abuse, it's going to affect their medical care outcomes. Again, so it's quite comprehensive. Social isolation, loneliness. We know that loneliness can lead to withdrawal. Withdrawal is a quick trip toward deterioration. I mean, so we need to work in our communities as well to keep people as healthy as possible. Mm-hmm. Number one, though, in order to convince the physicians, we had to show that there's a reduction in cost. Right? Everybody's interested in cost. Yes, it's the right thing to do, and we want to do the right thing, right? We want to provide the best possible care, but can we do that in a cost-effective manner? And so this is what has driven this. And when you talk to politicians, that's what they're interested in. What are the costs? What's the money involved? How is this funded? Right? I mean, yes, it's the right thing to do, and we're all about that, but, right? If you can show the numbers now to show that there's a reduction in cost as well as improvement in treatment outcomes, some intangibles such as increased satisfaction for both the patients and the providers, and also promotion of independence within the communities. And that's been the big focus in the United States, is how do we keep people living independently in the community? It's where they would prefer to be, and it's much more cost effective. When someone goes into an institutional setting, they incur significant cost over what, right, the type of care they might need and could be provided in the community. And we have home health and other kinds of, we're taking the care into the home and training people to provide the types of care that are needed. Now, here's an example very quickly of an integrated model. This is the Beaufort Jasper Hampton Comprehensive Health Services in the Low Country of South Carolina. They provide services over a large area, right, and including telebehavioral health. And that dot on the upper right there, that's my wife. Right? Now, she has been in this for a long time. She's watched it grow and develop. So she's been part of an integrated process and a movement going forward. But that's her home office, that dot on the right. So she provides telehealth, telemental health, if you will, or telebehavioral health to clients that are largely located in the low country, right? Now, they do have brick and mortar establishments, and so people can walk into any one and receive that continuity of treatment, or they can also receive the remote monitoring and the telehealth care options that are available increasingly. It allows the healthcare now to reach into the underserved areas, and we certainly have those. A lot of rural areas that don't have the various types of services that we need. It also reaches into the schools too, and we can see we've always had nurses in schools. Well, now we have behavioral health in schools too. All schools in the United States now include not only nursing but behavioral health as well, because again, the integrated comprehensive approach. Someone can be seen in the school, they can receive a diagnosis, they can receive a medication, and the prescription can be picked up by the parent in the afternoon when they pick up the child from school, right? I mean, so it's not seamless and it's not a perfect system, but it's moving toward being a better system. Of course, there are challenges, right? Any kind of change always involves challenges. And what are the further challenges? Well, we've got to further develop these different capacities. How do we address the rising need in dementia care? We've been hearing about that today. And again, we all know these numbers, and the shortage of caregivers too. Oh my gosh. And then how do we provide the needed training and education for people involved in these different types of care? Because it's a paradigm shift. It's a conceptual shift towards seeing a new type of care. We're reframing our images of healthcare every day, right? We've heard about that through these innovative approaches in earlier presentations. These are new ideas, and this is going and taking us in a new direction. And we're also reframing our images of aging. What does it mean to get old, right? Is age, in fact, synonymous with disease, or can we be active on our own behalf and remain healthy for as long as possible? Because that's got to be part of the solution moving forward. We have to be able to prevent and offset and delay care as long as possible in order to have any types of sustainable programs in the future. I've written about this fairly extensively. I'd be glad to share that. I'll talk with anybody there. Thank you very much.
Thanks, Boss William. Yeah, fruitful talk. And I would like if you have to tell us about behavioral telemedicine assessment, behavioral healthcare assessment through telemedicine.
Geriatric care.
Behavioral health assessment through telemedicine. What you do?
Behavioral
health
assessment
through telemedicine.
Yeah, the tools are the tools that are used by clinicians nowadays. The cognitive evaluations, depression measures, if I'm understanding what you're asking. Yes. There are tools for this. I'll give you a quick example. My wife was working with an older woman who the physician would not ask about, did ask, do you consume alcohol? And oh, no, I'm fine. My wife found out in less than an hour that yes, she drinks a lot, and she's in fact an alcoholic. Using the assessment tools that we have for that specific type of behavior, she was able to get in and ask these questions. And when she told the physician about this, the physician went, well, that makes a lot of sense then. That explains things. But the physician didn't really ask the questions and didn't have the tools to go into detail with that. So she has more time. She's doing different things. And so her skill sets complement. So as part of the assessment process, just as the nurses do things that are complementary to what the physicians are doing, so the other members of the team now too, and involving the community members now, all of this can move out into the community, and the care can be provided there. So, but there are a lot of different assessment tools, and that's why it's a biopsychosocial approach, a team approach, if you will.
Thank you. Shukran.
Thank you so much, Professor William, for this impressive lecture. Any question?
Thank you very much for your presentation. It was wonderful. I have two comments actually. So like a decade ago, we were talking about patients who have Down syndrome who are beginning to
sorry.
age. Yeah, it's me here.
Okay, go ahead.
That were beginning to age. So this actually echoes what you were saying about treating cancer patients. Something else surfaces. So having Down patients who are becoming elderly, it's a different profile for the elderly patients. So I totally can reflect on what you were saying. The second comment is I've been saying for years that we can't be talking about preventive or successful aging as geriatricians alone. By the time we are geriatric patients, it's the prevention is actually limited. So we need to talk to the pediatricians and the internal medicine practitioners to actually start implementing the preventive measures so that we can actually have successful aging. This is my personal opinion, but I think it will be more successful if we start with the pediatric patients, like we were saying before the conference, encouraging the youngsters to start having more, engaging more in physical activity and leaving their mobiles a little bit and the smart devices and so on.
To be honest,
Thank you very
Huda, successful aging is not only our responsibility. In fact, it's not our responsibility, as you said. It's the policymakers' responsibility. I believe that every elderly person, before he's getting old, if we have a design for how to involve him with social interaction and having a role in the society, he will never have any problems of aging.
Yes.
But unfortunately, once they retire, they lose those impression or those social role or this role in the community in general, not only social services. So that's why they start with problems of aging.
Yes.
May I say something?
I absolutely agree. Go ahead.
As a preventive medicine professor, I agree that successful aging is a responsibility of all the community. So I think we should have a national health education program for the citizens, all the citizens, in order to have a healthy, successful aging. Practice exercise, eat right, sleep well, all the items of successful aging as a healthy lifestyle. So this is the responsibility of preventive medicine as a health education program, national health education program.
Yes, thank you, Dr. Huda. Totally agree. And
Thank
Dr. Hala, yes, I totally agree with your
Thank
opinions.
you.
Thank you.
I agree. I can, one additional thing, I'm very excited about the telehealth and the telemonitoring. I saw something really interesting just the other day. We have a diabetes problem in the United States, and now there's a patch, of course, that you can use with an app. And someone almost on television, and they said what they started doing was every time they ate something, they looked at it and they saw the little spike. And it helped them become much more aware of their habits and what they're eating. So I use that word there. It's almost like gaming the system, but they're using it now to say, well, what kind of glucose spike do I have with an apple? What do I have with a cookie? But it puts them so much more in touch with what's going on, and it puts them more in control over their lifestyle choices. And I think with the technologies now, we have so much more opportunity to be in control and to try to embrace this. I think we're going to see significant changes. And of course, policy, it is everybody's responsibility. It goes along with the whole situation. But I think we're going to see some remarkable things over the next 10 or 20 years in terms of monitoring and controlling our personal health. And then, well, we hope the politicians will be a part of that. And we hope their policymakers will be a part of that too. So
Thank you so much. And thanks for all the speakers today. And now this is the end of our first session. And we invite the chairpersons of the second session to start. Thank you so much.